Hey everyone, and welcome to the very first episode of the Irish Hematology Oncology podcast. This podcast aims to create a friendly and engaging learning space where questions are welcome and the focus is on simplifying complex medical information. Today we're going to ditch the harder hitting stuff for a moment, because before we talk about all the great things that anti-cancer drugs can do, we need to talk about the safe handling of cytotoxic drugs. These incredibly powerful medications are saving lives, but healthcare professionals need to understand the risks involved. Today I'm going to go through and break down the HSE guideline on the safe handling of cytotoxic drugs, and this podcast is going to be split into 5 segments. So our first segment is going to be understanding the risks that are involved. Second is going to be looking at the risk assessments. Then we'll look at the control measures that can be put in place. We can look at staff training, and I'll give you a few resources then if you want to look at where to learn more. Hopefully I'll try and make it a bit obvious when we're transitioning from one segment to the next. So let's start off with segment 1, understanding the risks. So imagine this, you're in your own bustling hospital. There are doctors and nurses rushing around the place. Medication is being prepared left and right. It's easy to focus so much on patient care that we forget about hidden hazards. But what if helping others could put your own health at risk in the long run? It's not something we like to think about, but we have to. So let's talk about the nature of cytotoxics. These drugs work by targeting rapidly dividing cells, which is one of the hallmarks of cancer. The catch? Well, some of our own healthy cells also are rapidly dividing and also have that quick turnover, like those that are present in our hair, our digestive system, and bone marrow. That means that cytotoxics can affect them too. Here's where things get a bit tricky though. Hazardous, that term, isn't just about chemotherapy infusions that you see on the wards. Here's why this is important. Other category drugs can also be deemed cytotoxic. Hormonal therapies, some treatments for conditions like breast or prostate cancer fall into this category. This can surprise a lot of people. Antivirals, certain ones, especially if you need them for a long time or if you have a weakened immune system, can have cytotoxic elements. And other categories as well. The HSE and other groups are always updating their list of hazardous drugs. That's because it's not about the disease the drug treats, like cancer, but how the drug actually works. So let's talk about the roots of exposure and why it's insidious. We're not just talking about dramatic spills or needle sticks, those are risks too. Think about these daily things that you do in your practice. Inhalation, handling powders, or those tiny air bubbles that you see when you're setting up IV lines, or a leaky connection. Drugs can get inhaled in many different ways, and that bypasses a lot of your body's defenses. Skin contact. Even a small splash while prepping, touching a contaminated surface in a patient's room. Some of these meds get through standard gloves shockingly fast. Accidental injection. Obviously, needle sticks are a worry, but don't forget about splashes, especially with cuts and scrapes. Ingestion. Yeah, look, that sounds weird, but think about it. You skip washing your hands before grabbing a bite, or maybe adjust your mask after handling meds. Invisible residue can get transferred that way. And patients' bodily fluids. This is a growing concern. Urine, vomit, blood, even days after patients get chemo, the drugs or their leftovers might still be present. Nurses, cleaners, anyone touching linen, they need to know that they're at risk. So we need to also understand the long-term risks. So before we dive into how to actually minimize those risks there, let's take a quick step back and talk about what we're really trying to protect ourselves from here. Exposure to cytotoxic drugs can have both immediate and long-term consequences, and understanding these categories is key. Here's a breakdown of 3 key terms you hear a lot in discussion about cytotoxic safety. So mutagenic. These drugs have the potential to damage our genetic material, our DNA. That damage can get passed on to future generations, which potentially increases the risk of birth defects or certain cancers in children of exposed healthcare workers. Teratogenic. This term refers to the specific risk of birth defects. Cytotoxic drugs can disrupt normal fetal development, especially those during those critical first few weeks of pregnancy. And carcinogenic. We all know this one. Carcinogenic means something that can cause cancer. Long-term exposure to cytotoxic drugs increases our own risk of developing certain cancers later in life. So let's hit pause here at the moment, right? I'm not intending to scare. I'm telling you this hard stuff because I want you to understand how serious it is, and not to make you afraid. Knowledge is our first line of defense. The reality is, even with small amounts, the risk adds up over your career. Think of 1,000 tiny cuts rather than one big injury. This is why we have to make safety a priority for ourselves and for the next generation of healthcare professionals. Okay, let's breathe for a second. We'll take a little break, and when we come back, we'll tackle the first cornerstone of workplace safety, the risk assessment. Okay, welcome back to segment 2, risk assessment, right? So risk assessments, that sounds very official, but honestly, it's your most powerful tool for making your workplace truly safe. Think of it like detective work, figuring out exactly where the dangers are so we can target our protections. Here in Ireland, the HSE have a great guideline on managing cytotoxics. It's got a clear step-by-step risk assessment process. Yes, it means more work up front, but it's about protecting you and your team's health, and that's worth it. So let's go through the risk assessment step by step. So step 1, list every hazardous drug you use. That seems basic, right? But remember, cytotoxics go beyond chemo. Remember that list I said before, the hormonal therapies, antivirals, and other categories. But make sure you list all of those. And check the HSE. They often have a list themselves, or some of the resources I mentioned later on will have a list of hazardous drugs that are cytotoxic. Okay, so step 2, who's actually at risk? Go beyond the obvious here. A good risk assessment digs deeper, right? Pharmacy, first of all. Naturally, pharmacists, techs, any support staff, the cleaners or stuff that are coming in, they're heavily exposed. Depending on how your workday is set up, everyone from the person who's getting the drug shipments to those doing the final preparation could be in this group. Nurses, obviously those that are giving the medication, but also anyone handling patient fluids afterwards. Think bedpans, vomit, even contaminated dressings or sheets could contain traces for a while after the patient got the drug. So you're thinking of your healthcare assistants in this scenario. Doctors, even if you're not handling the meds, the checkups after treatment, reviewing blood work, the tiny bits that could get on a stethoscope, keyboards closing, that's still an exposure route for doctors to be affected. Cleaning staff. This group is often overlooked, but they handle cytotoxic contaminated waste, clean spills, and might even work in the patient treatment rooms where residues are. Are they getting the training and the protection that they need? And the other workers then, so porters who are moving the meds, the maintenance staff coming in fixing equipment, anyone encountering meds or residues and surfaces, your setup might have less obvious exposure points, but think about it. And that's where step 3 comes in. Let's break down the journey of a medication and try and see where all of those routes of exposure might be. So let's use an example. So let's say a patient is getting carbapenem, right? So receipt and storage, right? How is it delivered? Are there special procedures in place for unpacking and safe storage? Then the carbo is prepared. Where is reconstitution done? Its environment, the equipment that's used, the process for getting it into an IV bag. What steps might release airborne particles? Then, once it's been prepared, it needs to be transported to the area. So what container gets used? Who carries it? How spills are managed en route to the patient area? Then it's administered to the patient. So the IV connection, the nurse's PPE, the disconnect process. What happens to unused portions? Are everyone aware of the potential exposures if a connection fails while adjusting lines, etc.? And then the patient care, anything involving potentially contaminated bodily fluids and linens, and waste and cleanup. So spills, sharps, any unused drug disposal, cleaning prep areas, and patient rooms. Every single point is a potential exposure point, and that's what lets us design specific protections. The HSE process forces us to think about those small, everyday exposures that add up. Did you know something even as simple as taking off the outer plastic wrap from a drug vial can release microscopic residue into the air? It's the kind of detail a good risk assessment reveals. So just a quick note on evolving knowledge. Look, this is important. What we know about the dangers of hazardous drugs is still evolving. Meds that were considered safe decades ago have been reclassified because of newer research. And the same vice versa, meds that were considered hazardous decades ago have been reclassified as well. So regularly checking your hazardous drug list against the most up-to-date sources is how you protect your future health. We'll take another short break here and we'll come back then for segment 3, control measures. Welcome back. Okay, so segment 3, control measures, building our safeguards. All right, let's build some layers of protection here. The HSE guideline tells us to think in a specific order. Tempting as it is to jump straight to PPE, that's actually the last line of defense when everything else is in place. So right, let's go through those control measures step by step in the order of that priority. So elimination, right? Elimination is always the best option. Start by asking the key question, can we get the same service outcome with a process that's less hazardous? If there's a way to do that while keeping patient well-being priority, well, that's brilliant. Can we remove the handling of a drug by one member of staff, let's say? Can deliveries be shipped directly into the aseptic unit receipt room, removing a risk to the dispensary staff? So you're eliminating one element of the process. Substitution then is the second factor that you can go in that order. So reducing the risk of handling. Think about where we can minimize the hands-on kind of stuff. As things like, are pre-prepared formulations available? If a drug's available, ready to use, you can take a bunch of prep steps out of the equation. Yeah, they cost a little bit more, but factor in the hidden costs of staff safety when making these decisions. And centralized preparations, right? Can a designated pharmacy area prepare high-risk meds, limiting how many staff are exposed elsewhere? The setup and equipment might be way better in a specialized space. So hopefully most of our products are being made in aseptic compounding units when deemed necessary, and that those who don't have aseptic compounding units are buying those stuff in from external compounders who are using those aseptic compounding units. The next step is to look at engineering controls and using our work environment as protection. This is where we focus on our physical workspace. Back in the day, hazardous drugs were prepared in open air hoods that did nothing to protect from exposure. Modern standards are higher. Here's what we should be looking for. So, ventilation. Those old laminar flow cabinets protect the drug from contamination, but not you. We want specialized biological safety cabinets or isolators that direct our airflow away from the person working. They're crucial for prepping or handling high-risk meds. Another engineering control that we can employ are closed system transfer devices, or CSTDs. These are all those high-tech safety adapters for syringes and IV bags. Instead of open connections or needles with leaks and droplets, a CSTD creates a closed loop. There's a bunch of different models out there, each with its own pros and cons. The important thing is that they're becoming the standard in facilities that take hazardous drug safety seriously. And there's a lot of guiding documents now that would make you appreciate the need for CSTDs. And the fourth step is administrative controls, procedures, policies, and access. Okay, these are like a little less tangible, but just as important. So let's look at access first of all. Restricted access. Can we limit how many people are even potentially exposed? Designated rooms or prep areas for cytotoxics make a lot of sense. This makes it easier to train, control the environment, and limit unnecessary traffic flow through the area. So what you're thinking there is probably from a pharmacy perspective, you're thinking, make sure that all of it is going through an aseptic compounding unit. But also for treatments, limit the number of wards that are designated to give chemotherapy. Your oncology or hematology day ward, and maybe an inpatient ward. Standardized procedures, how you prep, administer, clean up spills, get rid of waste. All of this needs to be detailed step by step. It's not about making things complicated for everyone, just making sure that there's consistency so safety isn't a guessing game. And signage as well. Clear labels on hazardous drug storage areas, prep rooms, and waste containers remind everyone at a glance. The goal is to make safety instinctive, not something we actually think about every minute of the day. And then finally, PPE, our last but vital line of defense. Okay, finally, personal protective equipment. Remember, this only protects the person wearing it. If there's a spill, a leak, or airborne particles present, PPE can't undo that exposure risk for the whole environment. But when the situation calls for it, it's indispensable. So let's look at the types of PPE. Gloves, nitrile or neoprene, often double layered, are usually the standard. Double check your own guidelines though. Some cytotoxic drugs need even more specialized materials. Did you know that gloves have an expiration date and that there's a permeation time, which is the time it takes to know how long you're protected before the stuff starts getting through the gloves? So make sure that the specs for all of your PPE are cytotoxic proof. Gowns is another form of PPE. These got to be closed fronted, long sleeve with snug cuffs and made of material that actually blocks the drug to handle. Your regular cotton lab coat is of absolutely no use here. Eye protection. So sometimes you might need goggles or a face shield depending on the task. Prepping is more high risk than giving an injection that's already prepared. A lot of times our isolators will negate the need for goggles or a face shield, but it's up to you and your own risk assessment as to deem what PPE is appropriate. Respirators. A simple surgical mask won't cut it for certain cytotoxics in some situations. If there's a risk of significant airborne exposure, you might need tight-fitting masks with filters designed specifically for this purpose. These are just examples. It's up to your own process and risk assessment to deem what PPE is necessary. Now, just a quick note on waste management. Cytotoxic waste is on a whole different level. It's a different beast altogether. Dedicated processes with color-coded containers, very clear labeling, and special disposal methods usually means that high temperature incineration is needed to destroy the drug residues. Your hospital should have a detailed plan, and that's adherent to the National Waste Management Strategy. And that detailed plan should know from the moment that waste is created till it leaves its premises safely, how the handling of that happens. Okay, we'll just have a quick break now. So staff training. It's an ongoing and rigorous process, right? The best equipment, the most detailed policies are absolutely worthless without proper ongoing training for everyone who interacts with cytotoxic drugs, right? Think about it. You can invest in the best closed system drug transfer devices, but if staff use them wrong, what have you gained? Let's break down why training is a non-negotiable part of the safety equation. So firstly, knowledge is power. Safe handling starts with understanding those specific risks of the drugs you work with. It's more than just going along and memorizing those HSE guidelines. It's grasping that a drug known to cause secondary cancers needs an extra level of respect. Staff need to buy into the why behind the rules, not just blindly follow them. Specific skills matter as well, right? Think about the nitty-gritty, meticulous prep techniques, the flawless use of PPE, the contamination minimization practices that nurses undertake when undertaking patient care. The spill response that's quick and correct. These aren't skills you pick up on the fly. They need to be taught. Those processes where sometimes you think that you're actually trying to protect a drug, you're also trying to protect yourself. Aseptic technique in pharmacy practice means that, yes, you're minimizing the risk of contamination of the drug, but you're also minimizing the risk of a needle stick injury as well. Procedures evolve as well, right? So do you handle all hazardous drugs the same way? No, of course not, right? An oral tablet is different from a liquid infusion, which is different from dealing with patient excreta after they've received treatment. Staff must be trained on the specific nuances for each drug and each scenario. And training isn't a one-time event, right? Sure, reviewing written policies is necessary, but let's make training a bit more engaging to make it stick better. Think about stuff like hands-on demonstrations. Watch one of your experienced colleagues practice under their supervision with non-hazardous mock-ups. This makes the procedures way more real. Scenario-based training, talking through situations like the IV connection has broken and the drug is spraying. What do you do first? Who gets called? This forces us to think on our feet under pressure and not just memorize a list. And then simulation-based training. So this is something that we'd like to introduce ourselves. So spill cleanup simulation, right? A designated cytotoxic spill kit should be around wherever the drugs are. The problem is you don't want to wait for a cytotoxic spill to occur to give staff that hands-on experience with what's in them, how to use the contents, and the specific cleanup protocol for different situations. So why not have a simulation whereby a fake cytotoxic spill occurs and that you have to do a complete simulation of that cytotoxic spill process and using that kit. And as well, you as managers, you might think about your own core team, but think of the training that goes beyond that core team. So think about all of the people who might be unknowingly exposed. Shorter focus sessions for cleaners, porters, the doctors who are reviewing the test results. Everybody needs an awareness training tailored to their potential interaction with those hazardous materials. And now let's talk about competency, right? So just because someone went to a workshop doesn't mean they're actually good at these high-stake tasks. How can we really be sure our colleagues are ready? So one form of competency is observation. So have a senior staff member or someone trained for this watch people handling cytotoxic meds or responding to exposure scenarios. Spot errors or bad habits right away for immediate feedback. Formal assessments. Consider written tests on understanding guidelines, drug-specific knowledge, and emergency procedures. That's one way of doing it. But also don't underestimate the role-playing scenarios and what I said earlier on, making someone walk through a step by step from donning the PPE to that final disposal. That tests both the individual and whether our training SOPs need a bit of more work as well. And retraining. Don't see assessments as punishing anyone. If it isn't up to the standard yet, then they need more instruction. So don't forget to retrain your staff. This protects them, their colleagues, and the patients. Training as well, it's a shared responsibility. Don't let the burden always fall on the managerial staff. It's not just about compliance. Don't view training as a box-ticking exercise to make management happy. This is about your own personal protection and the health of the whole team. Be an active learner, ask questions, clarify things you're unsure of, and never feel embarrassed to point out something if it doesn't align what you know is in the policy. And again, management. Make sure staff have dedicated time for training. I know, very easy to say, but it's important, and don't make it something that they have to squeeze in after a tough shift, right? Try and build your refreshers and those retraining programs into the schedule as part of the normal job. It's something that I can definitely improve on. We all should be able to improve on. Make it crystal clear, I suppose, that ongoing training and competency checks are top priorities. Okay, so we'll just go into a few resources now, and if you want to learn a bit more, where you can go and find them. So the HSE guideline for the safe handling of cytotoxics is your foundation. But the world of healthcare keeps moving forward, and so does knowledge and safety. Thankfully, there are great resources out there to help us stay informed and engaged. Let's highlight a few reliable ones. So, a few international resources. So, professional societies, think beyond Ireland's borders. If you're in oncology, groups like the European Society for Medical Oncology, ESMO, or the American Society for Clinical Oncology usually have sections about safety standards, new research, and best practices from an international perspective. NIOSH, this is the USA's National Institute for Occupational Safety and Health. NIOSH is a research leader when it comes to hazardous. There are comprehensive lists of hazardous drugs, drug-specific safety info, and research into workplace protections are a huge help. And then your pharmaceutical manufacturers' websites, so the likes of the HPRA, reputable companies making cytotoxics, they often have safety data sheets, which isn't found on the HPRA, but the pharmaceutical manufacturer might have it as well. And the handling instructions are readily available on their websites as well. So this helps you get very specific info on the safe handling instructions for that specific drug. And don't forget your internal resources. There's some great resources right in your own workplace. So experienced colleagues, seasoned nurses, pharmacists, and technicians have been handling these cytotoxics for years. They've learned through experience. Seek them out for informal advice on best practices, tips for specific equipment, or even just have a run through of a scenario for a bit of reinsurance. And incident reporting as well, right? Does your team have a way to report spills, accidental exposures, or even near misses? Sharing and analysing this data anonymously shows patterns. Take those lessons learned and use them to improve processes for everyone's safety. So I suppose to summarise, staying safe with cytotoxic drugs is a journey, it's not a destination. Guidelines evolve, new drugs emerge, staff come and go. What matters, I suppose, is the mindset of continuous vigilance, both for ourselves and for our team. Let's make safety an integral part of our professional culture, protecting ourselves and ensuring we can provide the best possible care to our patients for years to come. Thanks a million, guys, for joining me on the very first episode of the Irish Hematology Oncology podcast today. If this was helpful for you and you enjoyed it, please subscribe and leave a review. Your support helps me keep doing this and reaching more people with valuable information on all aspects of cancer care. Fill out the feedback form below. I'd love to get some guests to join me on this podcast journey, and also any topics that you have to suggest as well. And don't forget as well to log in that important CPD. An example can be found in the show notes below. And I'll always end this podcast with an important disclaimer that this podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or safety protocols like I discussed in this episode. Always consult with the healthcare professionals in your hospital for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local resources or national resources for the most up-to-date recommendations. Okay, guys, thanks a million. Catch you next week.